I'd like to say that we have Katie White, who's been working with our team. I'll introduce her a little bit more later on. We're interested in co-leadership, and we call it relational co-leadership. And we figure that relational co-leadership is a pair of people, and Joanne likes to call them a productive pair. That one, leadership does not occur by a single individual, which is usually the way you see it in the literature. It occurs through a pair of people. And this is really important in healthcare settings where you have to integrate diverse types of knowledge. Being with the patient all the time, seeing the patient, knowing what's happening there, versus the clinical knowledge that a physician may bring. You've got to take these different worlds and put them together well. So what we argue is that relational co-leadership, a pair, a productive pair, nurse and physician, will create what Jody Giddle calls a high level of relational coordination, occupational groups that trust each other, that work together well, that listen to each other, that are free to talk up. And doing that psychological safety, results in decreased waste, because you have a problem finding something, you don't hide things to gain power. What you do is you put it in a common place so you know where it is. And that makes you feel prepared when you go to see the patient, right? You have the information you need. You do what you need to do when you see the patient, right? And then if you're prepared in work, that has two effects. One is hopefully you do the job better. You get better outcomes for your patients. And the second thing is, as we all know in our own work, is when we're prepared, everything's in the right place, we don't get frustrated. And when you're frustrated, you get burned out if it happens regularly enough. So you get basically, and then if you get frustrated and burned out, you tend to turn over. And much of this model, except for the relational co-leadership, I found support for in a study of assertive community treatment teams for people with severe and persistent mental illness. Works very nicely. So, key point here is, through working together, we bring up issues, we fix problems, we make things work in a more standardized fashion, and you get better outcomes. Okay? Where we are now, we had a great time. In the VA, if we say you want to do qualitative research in various facilities, they immediately tell you that's research, and you have to go get IRB approval. But if you just say we're interviewing key informants to find out how to develop the survey, well, that's all right. And so we interviewed, Katie led that, interviewing key informants who were really great. We had a physician and a nurse at 4 different sites to talk to about their life. And then Joanne and I flew out to Palo Alto. We didn't wait for January. We're in Minnesota. We went out in October a little bit early. And had a great meeting with Paul Heidenreich and Anju said, hey, 2 members of the team. And this is, to me, one of the things that was great about that meeting. They had been our VA partners in Palo Alto. We'd been to Minnesota. And we'd never spent time together. And just having a day that we spent together working really made the team much more cohesive. And it was just building a relationship. It was really fun. Okay. So one of the key informants, though, the VA has some really positive things going on. If we talk to the Minneapolis VA, the nurse practitioner there, the doctor there, if another cardiologist says what's happening with the patient, he'll say, go ask the nurse. I don't know. And he defers to the nurse, and who's the expert on the patient, and they go back and forth. And so they have a lead physician who helps the other cardiologists work together with the nurses. And interestingly, the nurse said, not all cardiologists are like that. Some are a little bit more distant. Another VA has given one nurse some incredible autonomy to develop her own disease management program, and she's done it over 10 years. And a lot of autonomy, a lot of freedom to work. We heard all sorts of great stories, and I'm sure that we're not going to hear this at every facility that we go to. We hear that there are issues of physical space, layers, and Katie's doing an analysis now of incentives in the VA and how they sometimes force suboptimal action to meet the targets. Okay? So why does anyone care? Basically, when you have to put together 2 different pieces of knowledge, you need both pieces. That means you need both pieces to work together. It's a relationship. And the leadership comes from the relationship. And what we think is that strong relational co-leadership is the model for other people to see. Okay? It's not an individual anymore. It's in between those two people. And that's what creates the positive climate and everything else in the team. Okay? So we're hoping for a high response rate. We're out in the field now, and we went out in mid-June. We were at about 35% response when I last talked to one of our John June about the response rate. The survey measures waste preparedness, relational co-leadership. We're going to eventually merge it in with quality data, including readmission rates, so we can look at people coming back in. Okay, and we're hoping for high response rates. In fact, I'll start phoning people pretty soon if they'll let me. I'd like to get about 70 to 80% if we can pull that off. Okay, goals we have. We want to know more about the performance of the VA heart failure, and this model shows us the mechanism by which you improve the care team organization. We can get more knowledge about relational co-leadership, which I think will extend the organizational research field, which tends to assume that physicians have the leadership position because of high status, and I don't think that's right. And the other thing that I'm doing on another study with Katie is we've developed an organizational development intervention with OD and feedback and coaching to improve the team. And I'm hoping the results from the VA study, from the CHF study, will allow us to propose and come back to inquiry in about a year and a half with another study that's a randomized intervention to show that we can actually improve this thing and show that it is a real causal mechanism, not just with instrumental variables. Okay? In the real way.
They get it, right?
Yeah, you do it with the instruments first and then you do it. So Joanne Dish, School of Nursing, is the co-PI. Myself, Katie White, I've been working with. She's an expert in organizational development. Paul Heidenreich, cardiologist, who's the research lead at the CHF query in Palo Alto. Anju Sahay, who's the evaluation lead there. Minneapolis VA, Tom Rector, who's a pharmacist. And the great thing about working with a pharmacist is I tell him the drugs I'm taking, and he tells me better ones to take. And he's also a very good researcher on CHF. Adam Powell, who's a social psychologist and very much understanding of incentives in the VA. Yeah. Judy Wagner, who was here with me last year, who's a nurse practitioner. And anything you need to know about heart failure care in the VA? I could spend hours with her. It's just great to listen to her.